Hello all, this is the last lecture voiceover presentation by me for the semester. We will briefly review, followed by detailing Medicare and Medicaid, emphasizing Medicare. Then we will wrap things up by analyzing health systems globally and the application of economics to healthcare reform. This slide shows the essence of healthcare as to what is acceptable, adequate, affordable, and together, what is accessible and available. Review key terms. Recall the difference between macro and microeconomics. Macro refers to the big picture, such as inflation and interest rate trends, and micro is small scale, as in one's personal finances and a business budget. Economics as a subject studies the production, distribution, and consumption of goods and services. Or succinctly, it is the study of human behavior and its relationship between ends and means, defined by Lionel Robbins, 1932. So, health economics is the application of economic principles to understand problems pertaining to health and health care. Humans are economic capital, input, while healthcare is pure consumption, output. Key takeaways here. The following terms are similar, but not the same. There is a distinction between health and healthcare. If we all are consumers, then healthcare is a product or a service we consume. Health is determined by individual behaviors, guided by beliefs, values, and genetic predispositions. Recall, it is difficult to measure health since it's subjective. We do so via observed metrics. For example, one's blood pressure deviates from the norm. The same can be true for body mass index, as manifestation of a, quote, healthy weight. Now, diet is an important variable as it relates to body weight because dietary decisions are multifactorial. Dietary practices are guided by more than just personal preferences. Includes culture, religious beliefs, social influences, and what fits one's lifestyle. Likewise, healthcare need and want are not the same. And then the biggie is access versus cost. Access and cost are also not the same thing. We have access. You can go into any ER, even a private hospital, and receive care, most especially emergency care, but you may have to pay for it. This is the distinction. The collective mantra in recent times is about political activism toward equal access. But what is often overlooked are the variables that permit access, such as cost, location, and quality of care, as opposed to quantity or the volume availability of care. Let me illustrate what I mean by location. Say two people reside in Bonners Ferry, North Idaho. One is a high-income earner and the other is a low-income earner. Both need more complex, specialized health care for whatever reason. Say they need an oncologist. Do both have access to an oncologist? Sure. But both have an equal distance barrier to access due to their geographic location, regardless of their annual income. They can either go to Spokane or Coeur d'Alene, but there is nothing inhibiting access, except of course if their insurance provider dictates which hospital. Nonetheless, they have access. Back to access versus cost, apply the concept to a college education. Do you not have access to attend LCSE if you don't get the financial aid that you applied for? Of course not. There is nothing stopping you from attending. It's just that you may have to pay for it or pay a little bit more than you were wanting to. Let me go even further. And for the friend who did receive the financial aid, was he or she more deserving than you? You see this slippery slope. This too creates a disparity. We see unequal access in all industries, yes, even access to a college education. Economics applies to all facets of human behavior. Healthcare just stands out because people have politicized it. Many people, including nurses, report access is unavailable because the healthcare they envision is not free to the patient, or specifically, lacks among the poor. But as we will see in a few minutes, we do have, quote, free or very inexpensive and subsidized healthcare for the poor and other underserved segments of the population. There are more options geared toward this demographic than any other. A great example is the emergence of telehealth, which captures which demographic? Those located in rural areas. Now, not necessarily the poor and or elderly, but certainly those geographically challenged, right? I mean, it definitely qualifies as a physical barrier. Recall from the prior section, our high-level hospitals are in the cities, urban areas. But what has telehealth created? Improved access, from diagnosis to treatment to even follow-up care. And it has eliminated, in most cases, the need to travel. In this sense, the doctor comes to you rather than you have to find a way to get to the doctor. This also is why we see many clinics offer outreach care. Immediately what comes to mind is large hospital systems like Providence offers services throughout Washington state, for example, the Tri-Cities, and many of their specialty services even come here to Lewiston, Idaho. Okay, so let's briefly recall the law of supply and demand. Differentiate also between those who demand and those who supply. If price goes up, does our consumer demand go up or down? What is that relationship? Right? It shares an inverse relationship. Sounds like statistics, huh? If price goes up, we demand less. However, for the supply relationship, as price goes up, the higher quantity supplied. In this instance, it demonstrates a positive relationship. As one goes up or down, so too does the other. They follow lockstep, like birds of a feather flock together. Isn't that how the saying goes? And where the lines intersect, we have market equilibrium. Let's delve right into Medicare. Medicare really is the talk of the town in politics and everywhere when it comes to the topic of health insurance, particularly when advocating for health insurance for all. The pursuit of health insurance for all is not a bad idea. In fact, how could anyone argue against that? It is altruistic, selfless to want to see that. But is it a reasonable precept? There are costs and consequences to every decision. Government or subsidized public health insurance programs include Medicaid, CHIP, or Children's Health Insurance Program, and you may see it as SCHIP, which are the individual state Medicaid CHIP programs. These are funded like Medicaid in that it is a joint funding, federal and state funds. This is a key reason why such legislation at the federal level that mandates state changes can be catastrophic because not all states are created equal. The needs in, say, Texas, where they have rich resources, is very different from, say, Kentucky. Or take population differences between California and North Dakota. These measures can create a budget crisis for the state. Idaho, Washington, Utah, and Oregon all have different SCHIP plans based on their budget and population needs. In which year was CHIP passed? 1997, under President Bill Clinton. And while we're at it, which year did HIPAA go into effect? 1996. Be sure to abbreviate that correctly. I often see it written as HIPPA, two P's. but it is HIPAA 2A's, Health Insurance Portability and Accountability Act. We will focus on Medicare, followed by Medicaid. See the eligibility criteria for each listed in the circular graph. I want you all to have a basic understanding of Medicare and its various parts. There is a Part A, B, C, and D. Medicare is big. It extends coverage beyond a hospital stay. Take a closer look at the eligibility circles for Medicare and Medicaid. Doesn't this look like Americans neglect the vulnerable or marginalized segments of our population? To begin, Medicare is a compulsory government entitlement. Age 65 or older, you are eligible. This is not based on need or financial status. Bill Gates gets Medicare. Now, can everyone have Medicaid? No. We'll look at Medicaid here in a minute. Let's continue with Medicare. Medicare hasn't been around that long, enacted in 1966. Although eligibility has expanded through the years, it was initially intended for senior citizens to help offset healthcare costs upon their timed retirement. And naturally, their healthcare needs are greater as they age, as we age, I should say. Eligibility now includes low income, those with disabilities, and with end-stage kidney disease. I talked about the 4 parts to Medicare, A, B, C, and D. Some of these are voluntary. I will detail each. Part A is the hospital insurance program. It covers inpatient services as well as hospice. Part B is a supplementary insurance that covers outpatient services, including a doctor's office and ER visits. This is voluntary and does require an out-of-pocket monthly cost by the patient. Note, Parts A and B are tax-financed. Part A is financed through federal taxes, like Social Security, and Part B via the monthly premiums collected and the general tax fund. Part C is often referred to as the Medicare Advantage. It is Medicare plus Choice, enacted in 1997. Recall the same year the CHIP program emerged. See, these federal programs really are pretty new from an historical perspective. Part C is a private insurance plan that competes, there's that word, competes, with the standard Part A and B, referred to as Medigap. Think of it just as the name implies. It fills the gap not covered by standard Medicare. Commonly, we see Blue Cross Blue Shield fall under this umbrella. And finally, Part D is also an option under Medicare Advantage that entails a prescription drug benefit. This is voluntary, but intended to help offset drug costs for seniors. The Part D is only offered by health insurance companies and HMOs, not the government, so no Medicare or Medicaid options. Part D is even more new, enacted in 2006 as part of then President George W. Bush's MMA bill, Medicare Modernization Act of 2003. Although it is an entitlement benefit for seniors, it promotes privatization of prescription coverage while preventing the government from negotiating discounts so that private suppliers can do so. A well-known example is Walmart's prescription drug program. So now, Medicaid. Medicaid was created for low-income wage earners. It also covers children of low-income families, pregnant women whose incomes fall below the national poverty line, and since the 1990s, mental health services. The cost to run the program is a joint venture between the federal and state governments. Although states are obligated to provide a minimum of federally mandated services, i.e., individuals compensated under the ADA, Americans with Disabilities Act, each state has latitude in determining eligibility and services offered. The federal government matches anywhere from 50 to 83% based on per capita income. The poorest state, Lowest per capita income is Mississippi, followed by Arkansas. I won't test you on that, it's just interesting. Good to report it's not Idaho. Let's go back to addressing costs and state budgets. We all maintain a home budget. We must also be cognizant of our local and federal budgets. Healthcare budget decisions impact us not only as nurses and other healthcare professionals, but as healthcare consumers, patients. There are so many variables that go into budgeting. Recall, budget development includes the capital budget and the operating budget. Capital refers to the dollar amount needed for the purchase as well as the anticipated duration of that purchase. For example, maintenance costs. The operating budget is more like the day-to-day financial needs of the organization. These expenses are determined over a specified time frame, the fiscal year, i.e. labor or salary costs. Remember, nursing is a huge overhead. All nursing service lines adopt a unit of measure. This includes inpatient and OR unit. Nurse manager wears an important hat since he or she is responsible to account for every dollar. Costs associated with ADC, average daily census, and HPPDs, RN hours per patient day. We then account for money coming in. How do the budget decisions align with payments received? Another thing to consider is how low reimbursement rates affect more than just the cost to provide patient care. When reimbursement rates are low, the hospital becomes more restrained to secure contracts for much needed and desired programs, medical equipment, etc. Say the hospital wants to provide the latest and greatest new MRI machine. They may not have the money coming in to support such a large purchase, or they want to negotiate a health insurance contract for their employees, but need to ask for reduced rates. The term trickle-down economics is very real. What happens at the top trickles down to you and me. See the textbook for some common terms, such as how revenue and variance work. What do we get when revenue exceeds liabilities? Yes, profit, income. Remember, this is a good thing. In fact, profit is necessary. Otherwise, the business fails. When a business fails, this just doesn't affect jobs. It affects those who depended on the services provided. We see the ill effects of this, no pun intended, when a hospital shuts its doors. It adversely impacts an entire community. Hence, budget projections are key. Planning is key. I placed a downward slope because the reimbursement rates for physicians, mid-level providers, and therapists through Medicare, Medicaid is so low and continues to be slashed by the day. I won't state a specific number, but as those percentages update, I will include in the module. This leads us to those distributional decisions to avoid shutting the doors. I've said it before, but it's worth repeating. Just because healthcare is important and everyone feels entitled to it does not mean that we have an endless supply, nor is there an obligation to provide it. Healthcare is not utopia. I like the Willy Wonka chocolate waterfall scene. It's a great analogy in this instance. So, what do we have instead? Decisions related to scarcity. The classic saying, do more with less. And we only have so much to go around. A scene from the show ER depicts this perfectly. Go ahead and click on it. The clip is approximately 5 minutes. You'll see why it is appropriate here. Wow. Imagine this scene was from a show that aired in the mid-90s. Have things improved since? Something to think about. Think about at least as an informed student of economics. The biggest step toward reform occurred via the ACA, Affordable Care Act of 2010 under President Obama. The ACA is also known as Obamacare. Parts of the act occurred through executive order rather than through the legislative process. It was questionable if the individual mandate to insure was legal. Therefore, the ACA made it up to the Supreme Court to determine its constitutionality, and it was upheld as a commerce tax. Future presidents also have executive power, which is precisely what happened in 2019 when then President Trump proposed repealing the individual mandate portion, the enforcement to purchase insurance, typically via the state exchange market or pay a fine, which was passed through a congressional tax bill. This act essentially unravels the ACA because the mandate is what financed it. It ensured a steady flow of payments coming in. Here are the goals when implementing such reform. Control cost and restrain behavior by creating a healthcare system that is centralized, one single payer. Little by little, get rid of private insurers and regulate through restrictive laws and price ceilings. The term across the board for all resonates with what has since emerged as the Medicare for all mantra, or some variation of a single-payer health insurance platform. A national structure is appealing for a few key reasons. A single central payer makes billing and administrative costs easier and perhaps less costly. But of even greater interest is the concept of healthcare for all. This infers equality as well as equity. Uniformity is like saying, we're all in this together. It essentially implies there is a social responsibility that exceeds individual rights. This premise guides decisions related to moral concerns like sin tax and legalizing drugs, i.e. marijuana, and even the drinking age. Okay, I digressed a little bit. Back to health insurance coverage. Do we have equal health needs? Equal health care needs? Utility is 100% subjective based on so many factors, such as one's age, health condition, genetics, hence why I challenged each of you to rethink price ceilings. It's analogous to saying all surgical patients or ED admits are the same. We know that is not the case. Here is what the ACA proclaimed. Implementing 5 key strategies. Some of these are okay. In fact, we could argue are necessary if we expect to make some meaningful changes toward reform. But even so, now looking back 12, 13 years, have we accomplished all that was intended? For example, does everyone now have health insurance and therefore access to health care? Has the ACA eliminated health care and subsequently health disparities? This is not a Democrat or Republican thing. It is an American thing, since the act affects every one of us. The various stipulations implemented under the ACA had this key intention to offer care to all while restraining costs. Wait, this statement seems contradictory. Is increasing care supply an option while decreasing costs? This may be economically incompatible. How can you offer something to everyone, picture Willy Wonka's chocolate factory, while also reducing costs? How? Primarily by rationing. We have to. We do not have an endless resource, and we never will. We have scarce resources. Another relevant consideration is the implication medical technologies have on costs. Growing societies have growing healthcare needs, and along comes technology to improve and save lives. Medical technology, like all technologies, have boomed, really quite a bit since the 1980s. Everyone wants the latest and greatest and wants it now. But when it comes to medical care, great, bring it. I mean, this is how we get things like minimally invasive surgical procedures, high-tech prosthetic limbs, and heart and brain surgeries without an incision. When you think about it, technology hasn't just brought us an iPhone or high-tech vehicle, it has revolutionized American medicine. The ACA increases federal or national oversight. It really does place power in the hands of the U.S. government as a collective pursuit. Gradually, if left untouched, the ACA would phase out private health insurance altogether and create price caps on the healthcare industry. This can range from pharmaceutical and medical device taxes to price caps on salaries. You may think, what, salaries? Yes. When the government controls healthcare, it controls the entire industry. Now, with price ceilings, remember I said we would look at this in more detail. Price ceilings sound good because they are intended to control costs, but price ceilings assume people will decrease use. Will they? This is where consumer behavior comes in. And if utility did decrease, would it happen on a large scale? Either way, spending is subjective. So what happens? Costs must be controlled. Controlled via mandatory fee schedules, global budgeting, and the rationing of resources. Rationing simply means reducing access to the commodity or service. The ACA Affordable Care Act did just that. The program expands government oversight and control via increased regulations, employer and individual mandates, and expands the public sector insurance. For example, Medicaid and the state insurance exchanges. National Health also assumes control over which services and providers and medications are covered. We witnessed this during COVID when the government opposed use of off-label therapeutics to treat COVID. There exist a few comparative programs. Examples include Canada's NHI and right here in the US, state programs from Oregon and Massachusetts. Canada's NHI, National Health Insurance. In this structure, there exists first dollar coverage, no limits imposed, no copays or deductibles. The program is administered by each of the provinces. It is tax financed, that is, there is a universal program with a universal budget. This means the governing body negotiates what amount will be spent on health. This is where we get the wait times, or even in some cases, no times, because those specialized or niche healthcare services and providers are just not an option. It does not go much beyond primary care, prenatal and birthing care, and basic preventative services, including basic dental and vision. There is a great deal of debate in the US about emulating Canada. Again, as an informed, I emphasize that word, as an informed student, what are some reasons for lower cost in Canada? By the way, a lot of these reasons are also true for other countries. Lower costs are due to 1, population density, 2, less money allocated to research and development and technologies, and 3, fewer incentives. Areas that are no match to U.S. healthcare may include, but not limited to, the quality of care and advancements in A, rare diseases, B, cancers, C, birth defects, and D, chronic conditions. It's not on the slide, but Germany is another example of a socialized SI health insurance program. The government mandates financing via employment. If not employed, one may access other public sources for assistance. For example, the Federal Labor Administration. Private not-for-profit insurance companies called the Sickness Fund collect from the employer and employee. Many residents choose to purchase a supplemental insurance policy so that they can seek health care outside of the national system. Other considerations include life expectancy. Look at Japan, for example. And finally, we must consider overall health status. Going back to the US, Some of these factors are necessary when advocating for health. Why? Take Medicare for all. Americans live a lot longer now. When Medicare was enacted in the 1960s, life expectancy was lower, so the length of time people would need Medicare was not too bad. Take also chronic conditions. I suppose you could say age and chronic illness go hand in hand, but nonetheless, those do create more healthcare needs, therefore, greater costs and resources. But now we are seeing younger people get a lot of the once coined as aging diseases. What comes to mind? What comes to mind for me immediately is type 2 diabetes. Look at the strain that has created on our healthcare system. Morbid obesity, too, cardiovascular disease. Americans generally are not viewed as the most healthiest population, true, yet we still survive. Why? Ironically, it has a lot to do with Americans themselves. This includes us. At the state level here in the US, the two programs we'll review in this slide are Oregon and Massachusetts. Oregon has the OHP, Oregon Health Plan. This is a statewide health plan established in 1994 to expressly ration health care to Medicaid beneficiaries, patients. It also legalized assisted suicide. So, what kind of precipitated this was the fact that Oregon's Medicaid expenditures were becoming too great. The state legislature ranked medical condition based on severity. If considered low risk or non essential, those services are no longer covered. The benefit Oregon claimed is that greater coverage can be achieved by denying services to those few who need costly medical care in exchange for benefits received by the greater population. Simply, it is a system of survival of the fittest. According to Oregon's Prioritized List of Health Services 2020, cancer treatment is limited according to relative life expectancy, while assisted suicide services are fully covered. As new data on the OHP emerge, I will include in the Canvas module. Massachusetts is referred to as the Romney Care, like Obamacare. In fact, Obama claimed a lot of the premises of the Affordable Care Act were guided by Romney Care. It requires all residents of the state to have health insurance. There were only 3 insurance companies in the state, and they were all nonprofit. Because of the increased number of enrollees and the state legislature's mandate, the insurance companies were prohibited from increasing premiums. So what happened? They denied taking new enrollees. Now, this created quite the pickle. Residents were required to insure, but the companies were not permitting them to purchase a health policy. The insurance companies appealed to the state legislature but lost. This occurred in 2010. This was a bad situation, certainly one of those unintended consequences. This too, as more data are available, I will add to the module in Canvas. So let's check your knowledge. One of the most serious weaknesses in traditional Medicare is that, I'll give you a minute. The answer is C. It provides poor insurance coverage for unusually long hospital stays. If you didn't know the answer, you will after you read the assigned chapter. Great. Let's wrap up. Having analyzed the effects and intentions, or should I say the means and the ends of the Affordable Care Act, and from our current vantage point, what are some possible free market solutions to reform healthcare in the U.S.? The U.S. is made up of good people. As with anything, there are exceptions, of course, but yes, people who are career-minded, motivated, altruistic, and just want life, liberty, and the pursuit of happiness. America really does have a positive presence in the world. Now, this may be controversial, but I will pose it anyway because I think it's true. We have global health because of American medicine. We innovate, we create, we strive to do better and to save lives in our pursuits and within our innovative spirits. Think about that for a minute. Why did you choose a career in healthcare? Delivered food and healthcare to war-torn countries has brought our technologies to poverty-stricken communities, has engaged in rescue missions throughout our great nation and abroad. Are we perfect? No. Can we learn and strive to improve? Yes, always. But are we bad? Do we need to be knocked down to size? No. As you see from the various videos and other supporting peer-reviewed resources, we have so much to be proud of and really ought to capitalize on. Capitalize is a good word to address this slide because using the free market to deliver healthcare and health services occurs through capitalism. Here it is more consumer driven as opposed to government driven, private versus public sector. Rather than restrain costs, we strive for benefits. Now, although benefits cost, that B, benefits, should exceed or be greater than our C, costs. This is essential when it comes to healthcare as opposed to, say, retail commodities, because healthcare affects lives and in many regards really is a matter of life or death. In a free market, we see the value in promoting HSAs or MSAs, medical savings accounts. Review these. Health savings or medical savings accounts. These personal accounts, if you will, are a promising alternative to using the third-party payer. Here, you, the individual consumer, has the discretion and choice to use which providers and facilities you want. You simply use your tax-free debit card like that you can contribute to. A lot of employers are matching employees to promote responsible health-related behaviors. Recall, when you do not see nor pay the actual sticker price, you consume more. Does that mean you need more? Not necessarily. Healthcare accounts promote competition, as does the topic of portability. You can take your health insurance over state lines into different employers. Insurance companies could compete for your business, as well as providers, because they see that you have autonomy in your options. You have choices. If they can't step up the ante, you go elsewhere. This is where innovation comes in as well. Yet they are expensive, but do they not improve and save lives? And if one is innovative, will not another come along to do the same? I put videos in the module to showcase some of the latest medical technologies, such as the Micra AV leadless pacemaker by Medtronic. Take that as an example. What do you suppose St. Jude and Boston Scientific, other medical device companies, did? And Medtronic itself? They all compete for the latest and greatest new technologies. Who does that benefit? Look at a local group of hospitals or surgical centers. The moment one remodels its ER or begins to offer additional enticing services, what do the surrounding facilities do? When you hear the talking point that corporations should pay more taxes, don't lose sight of the implications of this. Taxes will always trickle down to the consumer. Additionally, taxes restrain or stifle innovation because there's no incentive to do so. If you can't make a return on your investment, why invest? Apply this scenario to education. Why achieve a college degree in a profession that won't pay well, or at least provide an opportunity to generate the income to overcome the cost and sacrifice of that education? The free market is also what drives tort reform. Without reform in this regard, malpractice insurance premiums will never go down. This includes nursing malpractice insurance policies. But there was a lot to this, and it's multifaceted. For one, sad to say but true, legal tactics are financially driven. Whether a lawsuit makes it to court or settles out of court, an organization can be out of millions of dollars. Not a few thousand, millions. Likewise, if you are personally sued, you are out of your livelihood, potentially, in all or most of your assets. This could mean losing nearly everything you ever worked for. This ends the fourth lecture presentation, but also wraps up this semester. I posted the course description as listed in the LCSC course catalog. Look and ask yourself, did Dr. Christie accomplish this? I really do hope that you have learned a lot and have several takeaways. This class is crucial since it challenges each of you to think beyond your area of practice and disciplinary proclamations. Although it may seem politically driven at times, it is. It is because healthcare has become politicized, and healthcare in general has seen a great shift in the equality equity mandates. This is perfectly fine, except economically, we cannot ignore the implications. I look forward to reading the takeaway or class reflection discussion posts. Please do not hesitate to call or email with any questions. I've enjoyed you all. Bye now.